Good morning, everybody. So I'm going to talk today about this paper which I've conducted with colleagues in Trinity College in Dublin and Caoimhe in the Free University of Brussels. So the work was conducted under a Horizon 2020 project called PROACT. So everyone here is probably aware that the world's population is aging, and with increased age comes an increased risk of multimorbidity, which is defined as 2 or more long-term chronic conditions. So a study by Barnett et al. In The Lancet in 2012 studied prevalence rates of multimorbidity with 1.7 million people in Scotland across 314 GP practices. So what the study showed was that at retirement age, so between the ages of around 65 to 69, about 35% to 55% of the population had 2 or more chronic conditions. And if you jump 10 years then to 75 to 79, this increased to 52% to 72% living with chronic conditions. So the study also indicated that multimorbidity is associated with reduced quality of life and functional decline, and people with 2 or more conditions are more likely to die prematurely, be admitted to hospital more often, and to have longer hospital stays. So from an economic standpoint, it's estimated that there are 50 million people in the EU living with multimorbidity, and this costed around 700 billion per annum. And in the US, by 2030, 171 million people are estimated to have chronic disease, and 50% of these with multimorbidity. So unfortunately, for people living with multiple conditions, there tends to be poorly integrated and coordinated care. So, for example, care is inefficient. They might have different clinicians and conflicting advice. It's inconvenient and burdensome, so they may have multiple different hospital appointments, often on same days or different days of the same week. It's repetitive. They have to repeat their medical history at these different appointments. And it's potentially unsafe because of potential medication interactions and negative polypharmacy. So there's really a need to improve best practice around person-centred care for the individual at home, and empowering the person to self-manage their conditions with support from a care network is a key challenge. So in defining self-management, we've looked at Barlow's definition from 2002, and this states that self-management is the ability of the individual to manage symptoms, treatment, emotions, and lifestyle changes as part of living with a chronic condition. And self-management of multimorbidity is challenging. It requires engagement in multiple tasks, such as monitoring of multiple symptoms, managing well-being and lifestyle activities, sometimes with conflicting advice. Other challenges can include recognition of exacerbations of conditions, knowing what to do when an exacerbation occurs, adhering to complex medication regimes, communicating with a number of different healthcare professionals. So self-management is complex, and while the person with multimorbidity is usually the key person who's involved in their care and in negotiating all these different tasks, self-management typically doesn't happen in isolation. So many people with these conditions would have day-to-day support from their informal carers, from family members, from paid formal carers, and they'd have feedback and advice then from their healthcare professionals during clinical visits, or perhaps from their pharmacist day-to-day. So our overall goal within the PROACT project was to design a technology ecosystem to facilitate older people with multiple chronic conditions to self-manage at home with support from their care network. And so as part of this, the early part of the project, we wanted to understand the challenges that people with these conditions face, and also to get the perspective of their care network members in terms of the challenges they face in caring for people with multiple conditions. And we wanted to understand the design opportunities then for digital health applications to support self-management of multiple conditions. And this is quite important, as the majority of research to date around self-management of chronic diseases has focused on single disease management. So our prevalence research identified 4 diseases: chronic heart disease, congestive heart failure, COPD, so chronic obstructive pulmonary disease, and diabetes as the most common in the EU with the greatest financial impact on chronic disease management budgets. So these are the conditions that we've looked at in this project. Okay, so in terms of participants then, to address the goals, we undertook a large requirements gathering study with a number of participants across 2 EU countries, so Ireland and Belgium. So we held a number of interviews and focus groups with people, and you can see the list of participants down here. So the person with multimorbidity, informal and formal carers, formal care managers, various different types of healthcare professionals. So we had 125 people take part in total. More details on the demographics can be found in the paper, but all of the main participants, the PWM participants, were over 60 years of age, and they had 2 or more of the chronic conditions I previously mentioned. So we analysed the findings separately in Ireland and Belgium, and we had regular consensus meetings to agree on a common code structure. So we initially conducted a broad coding to cover the topics of interest in the protocols. And then within these broader teams, we did an iterative thematic analysis to uncover sub-themes. And then we derived notes from this. So the study resulted in quite a very large, rich qualitative data set for analysis. In this paper, we've kind of given a broad overview of some of those teams. But in some of our other work cited in the paper, we've gone into more detail in particular areas. So we've a paper focusing on medication management and one on care planning and goal setting for people with multiple conditions. So here are the themes that we discuss in the paper around the impact of multimorbidity, the complexity of managing multiple conditions, motivators and barriers to self-management, how lack of communication is a barrier to care coordination, and sources of support. So just for the interest of time, we just focus on 3 during this presentation. Okay, so the impact of living with multiple chronic conditions was repeatedly identified as very difficult by the participants. Participants seemed to have some sort of general awareness of symptoms related to vital signs, particularly blood glucose for those people who are managing diabetes. And there was less awareness of the importance of other symptoms and strategies for condition management. So, for example, diet and adhering to diets, or monitoring fluid overload assessment, for example, for people with heart failure. So one participant in Ireland who had heart failure said, "You're told if there's a sudden weight gain over a couple of days, then you report into cardiology. So that's one thing I'm able to do myself, but it's all the other parameters. I just don't know about them." So healthcare professionals in Ireland and Belgium were asked to identify all of the important aspects of self-care across the different conditions that we were looking at. So we brought these together then into this diagram, and we validated these then with the geriatrician in Ireland. So you can see for each of the conditions that there's quite a lot of activities to monitor day to day. And in the centre you can see all of the activities that are common across the different conditions. So many participants expressed uncertainty about knowing at what point a symptom becomes an exacerbation that they should then, do something about. So one participant said, so if you're judging for yourself, it's like with the heart, getting the pains or something like that, with the angina, is it just an ache, or is it what? How long does it stay, or when do I go and do something about it? And healthcare professionals spoke how it can be difficult at times to know what condition a symptom is a result of. So this can make self-management quite difficult for the person as well. So then in terms of barriers to self-management, the majority of participants perceived the individual diseases and comorbidities as major barriers to performing effective self-management. So for those particularly with COPD or with heart failure, breathlessness was a primary barrier to conducting self-management activities. The majority of participants then reported experiencing other comorbidities such as pain, back problems, arthritis, osteoporosis, as well as a lack of mobility as inhibiting their ability to even walk or get outside, which then negatively impacted on their ability to self-manage. So one person in Belgium said, "I cannot ride my bike or take a walk anymore. Of course, a doctor will say out of principle that you have to walk more to keep you moving, but if it's not possible anymore, it's not possible." So it was clear from the frequency with which such issues were discussed by participants that for many of these other comorbid conditions were often, they often actually required the person's entire focus and took their focus away from some of their other conditions that they were managing. And this was also alluded to by an informal carer in Ireland who said, so I don't find the diabetes so hard or her other health problems. It's just the mobility. The weight was her downfall and the lack of mobility due to the weight. So it was kind of a vicious circle. So that's causing the problems more than the diabetes. So one of the major barriers to self-management then obviously involved lack of information, which often resulted in frustration for our participants and a feeling of being out of control. And it was particularly problematic in relation to medication. So participants generally reported adhering to medication, but not necessarily knowing what they were taking or for what purpose. And healthcare professionals and pharmacists noted the importance of people having this knowledge, as well as knowledge on how to take the medications. So both pharmacists and GPs described examples of COPD patients not actually using inhalers correctly. So a pharmacist in Ireland said, it's hard to believe it, but this person was actually spraying an inhaler, which is meant to go down into your lungs, up their nose for 3 years. And they were actually putting the nasal spray into their mouth. So no participant in our study had ever had a personalised care plan or health-related goals set for them. Other stakeholders also conceded that it's not common practice, despite wide acknowledgement by all that it's actually very beneficial for people with multiple chronic conditions where help in sort of setting and prioritising goals can improve self-management and maybe reduce its burden. So from a clinical perspective, there are a number of reasons highlighted for this. The main one being time. So a GP said, they wouldn't be formal care plans. We don't have time to be doing those. Over time, we'd probably construct something that you would call a care plan, but it wouldn't be a formalised, organised care plan. It's work enough to deal with acute issues as a GP. And with GPs as well, there also seemed to be a reluctance to engage in sort of greater specificity around health and well-being goal setting for older people with multiple conditions, as there was a fear that this would constitute information overload for the person. So it would be too much to take in at a time when they're already ill visiting the doctor. So all stakeholders identified poor communication as a barrier to effective self-management and coordination of care. And communication amongst different healthcare professionals was mainly written and done via the postal service. And most highlighted challenges and issues with this, such as communication, long delays in receiving information, and sometimes not receiving it at all. So a pharmacist in Ireland said sometimes the GP will prescribe one thing, the next week they might be prescribed something else from the hospital. Sometimes I wonder, just looking at the prescription, does each one know what the other is doing? How much information is going from one to another? You might get something that would be totally opposite sometimes on a prescription, or sometimes it might be the same thing. They could end up doubling up. And because of these issues, the participants in our study felt responsible for communicating information to the different healthcare professionals. So they said things like, the doctor regularly asks me for, what medication are you on? And he'll then write the prescription. And it's up to me to keep them informed. But with so many different conditions, this can actually get quite challenging for the person. And clinicians raise the concern that, they might not be able to remember all of the information correctly. So one said, quite often the patient will go into the GP and maybe tell them something totally wrong. The doctor in the hospital told me to stop this or whatever. And he might have said the total opposite. So there's a lot of things that can go wrong. So we provide a high-level overview of some of the design recommendations here. And the paper goes into more detail on some of the specific examples of how we might implement these within designs. But the first design recommendation is to prioritise self-management activities to reduce complexity. So, for example, highlighting only the areas of well-being or health that need attention can reduce the complexity and the time burden of self-management. So, for example, a digital daily checklist could be a practical solution, highlighting daily tasks that the person has to do, and such as taking medication or attending appointments, and they can tick these off as they go. Algorithms can also help with prioritising tasks over time, so as conditions change, or on a daily basis, for example, if one condition is currently more acute. The second design requirement then is to effectively support self-management, consider the whole person, their comorbidities, age-related impairments, and the current status of their conditions. So our findings indicate that age-related impairments and comorbidities such as reduced mobility, frailty, or the onset of cognition problems means that usual or advised self-management routines usually can't be adhered to. So systems to tackle multimorbidity for older people should take this into account. For example, a suggestion to significantly increase activity levels, although it might be important for somebody with diabetes, should not be provided to somebody if they have reduced or impaired mobility. So building a holistic profile of the person is really important, and using analytics, for example, to ensure no conflicting or unsafe advice is provided is essential. And such an approach could make a significant contribution to improving coordinated care for people with multiple conditions. And so our final design recommendation then is to support people with multimorbidity and their carers to progressively learn how to digitally self-manage with context-relevant prompts. So it's evident that people with multiple conditions and their informal carers get little support with learning how to self-manage or actually self-managing their conditions. So supporting this should be a primary goal of digital systems. So we suggest looking to the theory of scaffolding from the field of educational learning. And so within a digital health system, scaffolding, for example, can be driven both from within the system or from people within the care network. And it can be integrated into various different functions and features. So, for example, reflecting on health data is something that's really important for self-management. And it could be, at the start of using its systems such as this, people could be encouraged to reflect maybe on single conditions first, so that they get, they learn more about the individual conditions, and then as they become more knowledgeable, they can be, progress towards reflecting on their multiple conditions. So that's all from me. If you have any questions, happy to take them.
Hi, Vera van der Wielen, KU Leuven. Thank you very much. Very, very interesting study and talk. I was wondering, I had a conceptual question. Do you think you can only use the label self-management in the context of chronic diseases already being present, or could you equally use it within the context of preventive care?
Yes, yeah, I think so. Yeah, I think. We didn't really look at prevention, and in this case, all the participants we worked with had these conditions. But yes, self-management, I think, is something that needs to be, that happens over time, and that changes as people change. Yeah.
Then I don't have to change the title of my paper. Okay. And then one more question. I'm for sure going to read the paper, but what was the median age of your sample?
The median age was around 76 in both countries, actually.
Okay.
Yeah.
Very nice. Thank you.
Okay.
Hello, my name is Robin Brewer from University of Michigan. So one challenge to self-management seems to be poor communication with and across these networks of carers and providers, as you mentioned. Mm-hmm. Can you say more about what we can do to help with that within this community? Because it seems to be a challenge that has persisted across many years. Curious as to what your thoughts are, what your study showed regarding that.
So I suppose there's two levels of communication. I guess there's the communication between the person themselves and their healthcare professionals, and also then there's the communication within the wider care network, maybe about the person. Are you talking about one or the other, or both?
It seems to be that both are challenges.
Yeah.
So either that your study provided evidence for.
Yeah. Okay, so I guess, one aspect that we've been looking at in terms of the integration piece is just in terms of digital tools to support different people having access to, the person's data as needed. So we've actually just completed the study on this, a deployment of the system that we've developed for 12 months, and we had people using it with members of the care network. And the only times that the clinicians actually logged in to this was during visits from the patients, and they said that it's slightly changed the nature of the communication, and that the person was more knowledgeable, and they felt they were able to better communicate with the person because they were less concerned about actually overloading them with information, because they had sort of had a set amount of knowledge already. In terms of the integration between healthcare systems and different clinicians, that's a much bigger problem that I think still needs to be addressed, and it's obviously different in different healthcare systems around the world. So I think, in Ireland, we know we're not going to change integration of care quite, at the moment with this type of technology, but by different clinicians just having access to this data is a starting point, we think, for that.
Wanda Pratt from the University of Washington. Very interesting talk. I like your idea of personalized care plans. So those kinds of complex care plans are really common in the pediatric population. So my question was, have you looked at those kinds of complex care plans for inspiration? And do you have a sense of how they might differ from what you would need in a complex care plan for, like, the elderly?
We haven't looked at complex care plans in that population in children, but what we have done is we've worked with geriatricians in the countries of interest here, because in Ireland anyway, so the geriatrician is really the one person who, the GP is the overall carer for the person with, who they see most often, but the geriatrician is the person who gets to spend most time with them and to develop these complex care plans with their multidisciplinary care team. So, for example, their MDT would have different, we've spoken to dietitians, speech and language therapists, physiotherapists, occupational therapists, and they would all contribute into a care plan. Where we haven't, we would have to look at research in that space, because when I say they contribute to a care plan, the care plans actually didn't exist. They weren't formal things that were written down, but they told us the types of things that people would be told to go and do. So it is something that we want to do as the next step, is to really in detail look at how we might digitise a care plan and who would be involved in that. So we'll look at the field of paediatrics. Thank you.